You guys have to tweet about this.
What phone is this? Hey, looks good. How much is it?
You haven't heard of the Optiven offer?
No.
I must excuse you invest too. Optiven has this amazing offer. If you make a commitment of 900k in any of their value-added projects, you get rewarded with a cool smartphone, bro.
Like, follow, subscribe, click the notification button. Join the Lookup TV movement now. The following program is rated PG. Parental guidance is recommended.
Welcome. If it is Tuesday, you know it's time for big minds to discuss big ideas and possibly come up with solutions to the problems that are facing Kenyans. Now, the COVID-19 pandemic has not only exposed the gaps in health systems and infrastructure, but also the high levels of vulnerabilities of individuals and households. The 2019 Kenya Population and Housing Census puts the number of the poor in the country at 19.5 million, but the pandemic has increased that. And according to the World Bank reports, by last November, income loss had pushed 2 million Kenyans into poverty. NHIF covers just 18% of Kenyans and 32 private health insurers only 1%. And today on the program, we'll be talking about the state of health in Kenya currently. With me on set, right next to me is Mwangi Peterson, who is manager, Jubilee Insurance. Welcome to the program.
Thank you. And
on the far end, we have Engineer Millicent Allo from Association of Medical Engineering of Kenya, AMEC. Welcome to the show.
Thank you.
And let's talk about the state of healthcare in the country. But before we begin, we have a story that has been compiled by our reporter, Wangari. Can we have that before we proceed?
What goes into your mind when you hear the cost of healthcare in the country? Medical bills continue to be one of the biggest financial burdens facing Kenyans, especially the poor and low-income earners, with about 1.5 million Kenyans every year pushed below the poverty line due to medical bills. This is due to the nature of healthcare system in the country. In Gekambura area in Kiambu County, we meet one family whose sentiments are painting the worrying picture of the cost of treatment in the country.
The 19th of March, we had this disaster that happened. The house caught fire at around between 7 and 8 in the evening. And when the neighbors came, they were not able to salvage the house. And unfortunately, when the people in the house were a lady, a woman, and her child. Unfortunately, when the disaster happened, they were dashed to the hospital, both the mother and the baby, and then later on transferred to Kenyatta Hospital, where the baby was pronounced dead 2 days later, and with a bill of like, what was it, 40-something thousand. Having a history of depression with the mother, we were able to interact with the medics in Kenyatta and told them the story. So fortunately, the Kenyatta understood our story, and they have both taken care of the injuries plus the other problem. And we're hoping that by the time she is discharged, she's going to be able to handle herself correctly. But the most unfortunate thing is that the bill, like in 3 weeks now, was at 440 something. If the lady is discharged tomorrow or the day after, we will not have funds to take care of the bill. And also, if the bill is also taken care of, a lady who comes home with recovery of burns will not be able to be accommodated in that small room. Taking into consideration, burns require a lot of hygiene.
Nyumba ilichomeka March 19, na nyumba ilipochomeka mtoi alikufia ndani. The baby was rescued, but unfortunately kufika Kenyatta mtoi akakufa. Right now we have Mercy at hospital, na Mercy yako hospital kutoka March 19. Went to ICU, but later alikatoka. Sasa hivi akona almost 3 to 4 months na we need help because the bill iko juu sana na bwanake hana uwezo wa kulipa hiyo bill.
But what happens in times of emergency? Many Kenyans resort to family members and friends to fundraise, which does not always yield results.
Mr. and Mrs. Kaurambi, they are my friends. Hii ni bill na bado hajapewa ruhusa cause the bodies need some here and there medication.
Okay. Yani ilikuwa shida. Tulipewa 72 hours, yes, but tulienda kwa chief, tukamwambia tupatie ruhusa, we extend. Tulienda kama a week.
Kijiji wakishirikiana na kanisa, then ile sako ya magari na drivingi wali contribute ile pesa ya ilikuwa imegharimiwa na mtoto the deceased mwenye alikufa. So watu wote wenye watu ushirikiana ni vizuri sana juu kama ni mahali kwingine mtu anatembezanga kama hali yake, unaona.
To avoid heavy spending on medical bills pushing many to the brink of bankruptcy, the Jubilee government in 2018 launched Universal Health Coverage UHC as part of its Big Four agenda, targeting to provide all 47 million citizens with affordable health care by 2022 to ensure availability of essential commodities and equipment at health facilities and remove user fees at levels 4 and 5 facilities. However, the big question still remains, is this achievable? Globally, countries are faced with health system problems which vary from one to the next. Healthcare systems in Africa have over the years suffered from man-made issues which cut across institutional, human resources, financial, technical, and political developments. South Africa has the best healthcare system in Africa with over 200 private hospitals in South Africa, which offer services that match those of Europe, Asia, and America. Followed by Tunisia, Kenya, which offers free maternal services, Algeria, and Nigeria. Carol Wangare Wanjiru, Look Up TV, Nairobi.
Thank you, Carol Wangari, for that report. And now back to our conversation. So that is the state of very many Kenyans, as we have seen medical appeals across social media from friends and families. And you see, these are times of uncertainty. So citizens are expecting their government to provide healthcare and food. And you know that NHIF covers only a limited amount of finances when someone is in hospital. And so for that uncertainty, I'll bring you in, Mwangi. Insurance is there for times when there is uncertainty. So during this time, there have been complaints. Our insurance companies, are they footing the bills for COVID-19 complications?
Thank you so much, Nalima, for that. Allow me to say that my name is Mwangi Peterson. I'm a manager, Jubilee Insurance. And let me go straight to the point and say that when COVID-19 came, it was something we can call something that people were not sure, something that was not expected. And since it was also uncertain, but despite it was uncertain, it could not be controlled. So insurance could not cover it because insurance do not cover something that cannot be controlled. But now, currently, insurance they are covering COVID-19 because now it can be controlled.
Okay.
Yes.
So maybe if you can just take us a little bit through the premiums, because medical insurance is something that Kenyans are now warming up to. But so what exactly does it take?
Thank you. The insurance premiums, they're calculated not as maybe people may think. They are rates that the actuaries came up with, and they're calculated even depending on the age of maybe a certain person, the age of maybe the parent or maybe the principal, the person who is taking the insurance. But when it comes to the insurance, you taking the insurance, it does not matter how much you're going to pay. Premium starts as low as 16,000 per year on a cover of maybe like 500,000 or maybe 1 million. that is the inpatient, but also what matters a lot, it is how much the hospital is going to charge you. Our rate, they are calculated depending on how much is the hospital charging. If the Aga Khan charges a certain percentage, name Aga Khan, MP Shah, Nairobi Hospital, all those hospitals, depending on their charges, e.g. when it comes to consultation, at minimum maybe they will charge, or maximum they will charge an average of 3,000 or 2,500. Now, when you're coming to pay insurance, that is what will be looked at, because insurance will not ask for something maybe which might be maybe lower of what maybe the hospital will charge.
Okay.
So that is what makes maybe sometimes maybe people say that insurance might be more expensive, but it is being charged on matter concerning how much is the hospital going to charge you also.
So from the services that are provided at the hospital, that is how insurance gauges how to charge.
Yes.
Okay, and I'll bring you in, engineer, at this point, because now when we talk about those services, so there is the fee for the doctors, and I don't know, the sophistication of the machines that are being used to treat people. You can talk a little bit about that.
Yeah, so thank you so much, Nelima. When you're talking about the cost of healthcare, from the engineering point of view, there are quite a number of items that are charged in the hospital. The hospital does not just sit down and come up with a charge out of nowhere. There's the fee for the doctors, as you've just rightly said it. There's the fee for the consumables that the patient is going to use here. There's the fee for the drugs. And more to it is that there's the fee for the equipment that are going to be used. Any patient who gets steps inside the hospital, right from the reception, there's an equipment that is used. From the time you're going to be done for observation, just to know what exactly is your problem, there is a particular equipment that is used on you. And those particular equipment, they have to be maintained. And maintenance is money. So the cost that the hospital put across to the patients is all these costs combined together. Yes.
Okay.
Yeah.
And you know, there are a lot of allegations that our medical system is in such a way that it focuses on managing diseases as opposed to curing. What are your thoughts on that?
I wouldn't really be able to say yes or no to that. And as the say goes, that everybody has a right to their thoughts. What I know is that we have a very good healthcare system across the country, both private and public sector. And the scientists and together with doctors have invested a lot in terms of treatment and even, having remedies that cure different diseases. So for the allegation that we're just managing diseases and we're not treating, I wouldn't really be able to agree with that, because we've really invested in a healthcare system in this country. We have sophisticated equipments that are treating different diseases. Right now, we have even cancer care centers in Kenya. And the other day, I think the government was posting of most of the patients are now not going to go to India, because we have cancer care equipment readily available in most of the public and private hospitals. And that goes across to dialysis. There before, we used to have people, going to different countries to be done for dialysis and even renal transplant. Now we do it all in Kenya. So, I think we've really had a good time. And I want to say that the doctors have invested a lot in terms of learning and even in terms of putting a lot of effort to study and to understand the diseases regionally.
Okay, and the cost of treatment in our facilities. So you have talked about the charge that is, there's the doctor's fee, and of course for the machines used and maintenance, and there's all that. But the cost of health in Kenya, as opposed to a country like India, where a large percentage of people go throughout the year. So what could be the differences in their health system and ours so that theirs is more affordable? That's why a lot of Kenyans just rush to India every year to get treatment.
Okay, you realize that in Kenya, we don't produce most of the things on our own. We actually import. If you look at the medical equipment that we are using, allow me to use cancer as one of the examples, because it has become like one of the major diseases in the country. Most of the equipment, actually not most, but all the equipment that we are using for cancer treatment, we import them. And you realize even in the term, in times of breakdown, we have to import the spare parts for those countries. We import them from India, we import them from the UK, we import them from different countries in order to enable us to maintain this equipment. And even the drugs. There are so many drugs that we import, the consumables, everything. Almost 80% of the items that we use in our hospitals are imported, as opposed to those other countries whereby they have their items, medicines, the equipment generated in-house. So that actually is what is causing the difference in costing between other countries and our country. And also looking at human resource, right now, the government is actually even struggling to pay doctors. You realize that most of the time doctors are threatening to go on the road for, strike so that they can be given an allowance. Even the nurses, the same. Looking at biomedical engineering, the same. A facility which is supposed to be having like 10 biomedical engineers is only having like 2 biomedical engineers. So with that, you realize that there's a lot of cost that is incurred during this time. And so this cost is passed to the patients.
Okay.
Yeah.
And Mwangi, NHIF covers just a section, like over 30%, slightly above 30% of Kenyans. So that is why there's the bill to make it mandatory for every Kenyan above 18 years of age.
Yes.
And even private insurers, they only cover a very small percentage of the Kenyan population. So what is the attitude of Kenyans when it comes to health insurance?
Thank you so much. Let me say that most of the Kenyans, they've become very much ignorant. And I'm sorry to say that. Because you notice that when we usually send our agents to the field to go and maybe sell insurance, you will find someone talking of, now, before this or before that or before this, where was the insurance? There is God. Yes, it is true there is God. But at a time, God has given you that wisdom to get to know that this can cover this, this can do this for me, this can do this for me. But people, they're totally ignorant of the way things they are going. But we thank God because due to social media and all that, people are getting more information. And at least now people are turning to be more positive. Because, Nelima, you will agree with me that you cannot cover someone who is not ready to be covered, and you cannot maybe go give someone insurance who is not ready. So first of all, that person must be there. You must be ready to take that policy. You must be ready for this. But since you're not, maybe when you're not there, no one will cover you. But that is why you find just a small percentage of people is what has been covered. Those people who are available, those people who are there to be covered, they're the only people. But on the other issue is that also you notice that insurance at first was for people who have money, people who are well up.
That was the attitude.
That was the attitude.
Like, you're able, then get an insurance cover.
Yes. But currently you notice insurance have come with different ways of covering people. There are those who will be covered as a group, as corporate, and maybe even as a company, where you only chip in something small. On the other issue, you chip in something small, and maybe the company deduct you, or you be paying maybe the rest of the premium. On the same issue, there's where you come to the company, like for example, you come to Jubilee Insurance. What we do, we give you, you're given a loan by the bank. You'll be paying the bank, but the bank pays the whole amount, the whole lump sum to the company. We cover you first, and now you'll be left with the bank, clearing the bank with the money with the bank, but you are at least fully covered. Yeah.
So these are some of the ways that insurance companies are coming up.
Yes.
So that they can ensure they've covered everyone, even just depending on their financial capacity and capability.
Yes.
Okay. And I know selling insurance is one of the hardest jobs. I was wondering about insurance, the tarmac. And then also Kenyans are a difficult crowd.
Yeah.
So it is hard to penetrate.
Yes. You know, when I was starting insurance, that is around, let me say, you know, for us, we don't count from the year from January to January. We come from where you started. That is around eight years ago. Let me say it was not simple. It was not something like you just get in, you collect money and go with it home. But insurance is not like hawking. Let me correct that. Even to the people who are watching us and people who are selling insurance, even to the agent, insurance is not all about hawking. Insurance is about being smart and knowing what the client wants and what is needed in the society and what the community want at that point. It is not like going to people, niko na maembe, niko na apples, do you want this, do you want that? No. It is selling what people want.
Okay.
Yes, what people are interested to hear from you, sell that.
Okay, and engineer, so expensive healthcare, does it mean when healthcare is expensive, then quality of service is given?
Quality and cost, I would say yes, and I would say no. Yes, because expense comes in the investment that a particular healthcare institution has put into their healthcare system. Yeah, and when you're talking about the investment, again, I will still go back to the items that I'd mentioned earlier. I'll go back to the human resource, getting qualified doctor. I'll go back to the, the sophisticated equipment, that is getting state-of-the-art equipment to man the hospital. I would go back to the surgical supplies and all that. We have people who are actually using generic, and their healthcare is very cheap. Because you look at the drugs that they're using, they're all generic. You look at the equipment they're using, they don't give you the quality, quality service that you want. You can go for an MRI, in one facility and another MRI in a different facility. You will get totally different quality of images. But what exactly does the doctor want in order to diagnose exactly what you're suffering from? So you will have to invest in a particular, high sophisticated equipment in order to ensure that you give quality service, you give quality images, and you also give quality, healthcare delivery services. I'm looking at, let's say, lab, for example. There are several times we actually go to the hospital and the doctor is not very sure what exactly could be the problem with you. So you are sent to go out and give your samples to the lab. And many a times we've had medication errors. Why? Because the lab machine did not give the right, the right results, the right results of the sample. So then, why is it not giving the right results of the sample? Probably it is a substandard equipment. That is what you are using. So then you realize that you invest in a lower standard equipment, you get medication errors, even led to fatalities because somebody has been given a wrong medicine because of a wrong result. What happens to that person? The rest is history. So yes, I would actually relate cost to quality of healthcare. And in the other angle, I'd also say cost does not relate to quality healthcare. Why? Because quality healthcare is all about, healthcare delivery is about a call. There are those, public hospitals who are giving very good services and their costs are very low. It's because of the human resource that is there. How are they trained? What is the culture that is there in that particular institution? So you can go to very good public hospitals which are very much affordable, but they give very good services because of the human resource that is there. Okay. So that's why I'm saying I can say yes and no in both. Yeah,
because there are private facilities, and for a lot of people, where if you go to uptown, because it's more decent there as opposed to downtown, so you'll be like. Shoes here, if you pay more money, you're like, there must be quality, as opposed to here, they'll be a little cheaper, there will be substandard. But is that always the case?
No, for healthcare, it's totally different because here we are talking about professionalism, we are talking about technicalities, and we are talking about in-depth learning of what's going on. So it can be a very good facility, but if it doesn't have what it takes, then it's still going to give you a very poor service in terms of healthcare delivery.
Okay.
Yes.
So, do you want to chime in on that?
Yes, repeat it again.
Yes, it was about the quality of service. So does it mean that when you pay a lot of money, then you're guaranteed of quality service?
Yes, thank you. Thank you so much because of that. Now, let me put it this way. Most of the people think that when you pay a more smaller premium, you're doing yourself more better. Mm-hmm. But according to the insurance, when you pay lesser premium, you are running away from certain benefits. But when you're paying higher premium, this means you'll get a more better cover. And let me give an example of what we have. There's a cover in Jubilee that you can be, if you take it, even if you're supposed to be, you're supposed to go to be treated out of the country, the whole cost will be for the insurance. We'll cater for that. You'll be flown out of the country, and everything, the medical bill and all that will be catered for you. Someone who is paying $1 million or someone who is paying 200,000, you cannot treat that person as the same person who is paying 50,000 or 30,000. Automatically, it got different levels.
Okay, but Kenyans don't have money. Now that's the point. When they only want to pay less and get more.
Yeah, allow me say that that is what has been a very big challenge in the insurance sector, because someone have paid something small and you want a lot. But I thank God also because of the insurance, because insurance is a pool where people bring money, you bring yours, engineer bring hers, and now it is put together that in case when you get sick, we treat you with this money. But we pray to God that all these people who bought insurance will not get sick at the same time. Because if you get sick at the same time,
then there's no money.
There is no money.
We'll come back with that after the break. We take a very short break here on Big Idea, but we'll be back talking about the state of healthcare in Kenya right now. Don't go too far.
Welcome to Look Up Guest House, Retreat and Prayer Center. When you first come in, we will be happy to receive you at our reception, then proceed to our cozy and well-equipped accommodation facilities. We aim to provide our guests with a unique, comfortable and worthwhile experience. Here at Look Up Guest House, we provide our guests with a continuous supply of room amenities. A cool environment for all your retreat activities.
Look Up Guest House, Retreat and Prayer Center. For reservation, contact us on info@lookupguesthouse.org or call us on 0746 788 707.
Solomon acquired knowledge and wisdom, and that is what made him to fly to the levels that he did. So the world that we live in, if we can only acquire knowledge, we'll be able to walk.
The reason is you can have everything, but without knowledge, you find like there is dimension, you are limited.
And you shall know the truth, and the truth that you know will set you free.
There is a knowledge that is inside of you that you are not aware about, that you can be able to explore, that you can be able to do all these things.
So knowledge is powerful. That's why Jesus said, and you shall know the truth about a matter, about a skill, about a thing. Let me ask you, why do people have coaches?
Welcome to the Natural Juicing Center. We are a unique organization that seeks to provide the community with an alternative healthcare option. We specialize in the use of a natural holistic system that focuses on building health through cleansing and nourishing of the body. We utilize a variety of natural health promoting methods in our services, which include juicing therapy, hydrotherapy, colon cleansing, massage therapy, and a comprehensive cleansing service, among others. Our juices are freshly made and tailored to each and every client's individual needs after evaluation by our team through our free consultation service. You can now book for any service or order for food supplements on our website www.naturaljuicingcenter.co.ke. You can also visit our center in Kahawa Sukari, house number 1334, Kahawa Sukari Avenue. Natural Juicing Center. Your health is your wealth.
Like, follow, subscribe, click the notification button. Join the Lookup TV movement now. Now.
And welcome back. Thank you so much for staying with Lookup TV. The hashtag is Big Idea right here on Lookup TV. Nancy Nalima here, and with me on set, talking about the state of healthcare in Kenya right now. Right next to me is Mwangi Peterson, a manager, Jubilee Insurance, and on the far end, Engineer Millicent Alo of Association of Medical Engineering of Kenya, AMEC. And now let's talk matters COVID-19. We know the pandemic, it has paralyzed a lot of systems, and it has also exposed the gaps, the holes that are existing in our infrastructure, be it education, and now in this case, the health system. So, Engineer, we can talk about oxygen. You know, before, we didn't talk much about the oxygen because it was only for critical patients, but now we have more of those patients because of the COVID-19 pandemic. And you know that we've had the shortage. So what does it take for us to have oxygen in our facilities?
Thank you so much, Nelima. Oxygen has become a very big priority. It was before, and it has always been. But COVID-19 has actually proved that it is more priority than even the drugs that we're using in the hospital. So there are 3 levels of oxygen usage in the hospital. You can either decide to have a plant. An oxygen plant is an equipment that generates oxygen on its own. It's very expensive, and most of the hospitals are unable to afford it. Secondly, you can decide to have a liquid tank. Oxygen liquid tank is a oxygen supplied in liquid form, then converted into gaseous form. And this, you'll have to buy it from the vendors that are supplying oxygen in the country. Then finally, you can also have oxygen cylinders. They are small cylinders like the like the cooking gas cylinders that we are having. However, you connect them in one centralized area and then you supply the entire hospital. Okay. So majority of the hospitals, both private and public hospitals, initially before COVID-19 used to have only oxygen cylinders, which are connected in a centralized place. The centralized place in engineering term is called a manifold. So majority of the hospitals used to have the oxygen cylinders connected in a manifold, and then they supply the entire hospital. Due to COVID-19 pandemic, the consumption has gone so high, and it has proved that manifold can only be able to supply a given number of consumption. When the demand is so high, then it will actually choke, and it cuts off, and it's not able to supply. So initially we have very few vendors who used to supply oxygen, and they were not able to cope up. They're not able to cope up with the current demand of oxygen, especially during this 4th wave. As we speak right now, I have a number of people who are camping at BOC. BOC is one of the gas companies that are supplying oxygen, waiting and spending. They are waiting for oxygen to be generated, and then they are packed into cylinders and brought back to different hospitals. And I know the government has done a lot in terms of the oxygen generation, and I'm aware that 23 oxygen tanks are being supplied in different county hospitals. Yeah. And we believe that in the next maybe couple of months, the government will be able to supply the entire 47 counties. However, that is not enough. What I would advise the government is let us invest on the oxygen generating plants. Because with that, it is a free generated oxygen. The only thing that you will need to do is to maintain the plant, and then you will have your oxygen supply continuously throughout 24 hours. Mm-hmm. Yes.
Yeah, and oxygen seems to be very expensive because when we see the patients that have been admitted in hospital, COVID-19 complications, then, okay, of course there's a shortage of them, but even now being on the oxygen machines, then the bill goes by the day to very exorbitant prices. So then Kenyans who are in need of the oxygen but are unable to foot all that, do you think then having the oxygen plants will enable us to at least lower the fee if we have it in more supply?
And Elima, that's a very good question because we as the Association of Medical Engineering of Kenya have been pushing the government to remove taxes from the oxygen generating equipments. Because the moment they land here, the investor would want to recoup their funds back. You know, and right now the COVID patients are not getting the normal oxygen. The normal rate of oxygen supply to the patient is around 15 liters per minute for normal patient who is not COVID patient. But right now with the COVID patient, they want at least 60 liters per minute. Look at that increase from 15 to 60, and all of them. You might find a whole ward of 60 beds are having all COVID patients. But you see, if we are having the tax on the oxygen supply equipment, then it means that the investor would want to recoup their money back. So what we have been pushing as the Association of Medical Engineering of Kenya is that can the government have the taxes out of all the equipment that are giving oxygen to the patients. Any oxygen therapy equipment should not be having a tax. For a patient to be given oxygen, is not taking oxygen and giving it to the patient. There are so many other things that are supposed to be connected before the patient receives this oxygen. If, for example, we are using a plant, the oxygen will come from a plant, you will have piped it through to different wards, then at the ward level, you will put a pot whereby you will be tapping that oxygen from. When you tap oxygen from that pot, you will still need something called an ox therapy kit. It is a kit that has a flow meter which shows you how much the patient is getting. It has a humidifier because most of the COVID patients need to have humidified air. You give them dry air and already they are affected, then they are not going to heal up very fast. So you need that humidifier and of course the gauge to measure the pressure that is coming to the patient. You see, all this is cost, and then with that you've not put the mask that the patient needs to put here so that you can concentrate the oxygen on the nostril. So with all this, remember these are cost. But as we are right now, all these things are taxed, and all this taxation is passed to the common mwananchi.
So then the cost,
the cost is very high. So for the patients, for the Kenyan who are not able to afford oxygen, it is very unfortunate that there's no way but to go to the hospital and get oxygen. And the other day, you remember BOC came up on media that, look, people are hoarding cylinders in their houses. And you see, this was just fear of unknown. Guys were actually just buying cylinders and putting in their houses. But these are people who are able to. Because one oxygen cylinder, when you're taking an oxygen cylinder, for you to have it, you have to pay a deposit of 40,000. You pay a deposit of 40,000, then you will be using oxygen in it. Depending on the amount of oxygen that is inside it, you will be need of refilling it most frequently. And refill depends on where you are going. So refill, at least a refill for for a medium-sized oxygen will go for around 5,000 per refill. And probably it will only last you for a day. So you see, it is a very expensive affair for a common mwananchi who is struggling to make ends meet here. Yeah. So it's very expensive. So I would say that if the government can actually ease the equipment, the imported equipment of the VAT, then the common mwananchi will feel less burdened to have this oxygen administered to them.
Okay, and the COVID-19 virus, it keeps mutating, and now we have the Delta variant. So Mwangi, for insurance companies, are we likely to see a situation where they shy away again from insuring COVID-19? Because you see, it's changing, and the Delta variant is stronger than the other variants that have been there before.
Let me say no. Because once you have a kid, you have a child, and the child continues to grow and continues to grow, you are able to make your plans very well and know that when my child will be in class 4, he'll be dressing this way. So the moment your child continues to grow, automatically you're planning yourself very well. Now, this COVID-19, it is doing the same. It is like a child who has been born, 2 days, weeks, months, and it continues to grow. Now, as it continues to grow, that gradual growth of COVID-19, we are also in the insurance sector, we are also planning ourselves in a more better way. Because the same thing is happening, the control of it is also taking place. Because we've seen doctors and even researchers doing a lot of research about it, on how we are going to control it. So insurance, there is no way they're going to shy away, but let me confirm that where we are heading to, very soon, insurance will be fully covering COVID-19.
Okay, let's say like Jubilee Insurance right now.
Yes.
How does it cover COVID-19 ailment?
It is so unfortunate, but it is at least by now, because we say that insurance were not covering COVID-19, but at least by now, insurance like Jubilee Insurance, we are covering up to 500,000 of maybe of our patients. But at least now from that, any bill from that, it is a story that we need to sit down and see how we are going to do about it. But at least up to 500,000 we are covering.
So say there is someone who has been admitted and is in hospital under oxygen. So you see that will just take a few days and they'll already hit the 500 mark.
Let me say not just a few days. It depends with which hospital you are. You remember where I told you, the amount that someone pays to the insurance depends on the payment, on the cost of the medical, on the cost of how much the hospitals they are charging is what matters. The same 500. If you go to a more cheaper hospital, maybe that 500 might cover you fully. But the more you, the point you go to a more expensive hospital, you see now 500 will be acting like 10,000 in that hospital.
So again, we have spending and versus quality. That whole conversation again comes through.
Yeah, that is a challenge currently we're having. Because if you tell someone to go maybe to a hospital like Metropolitan in Buruburu, maybe that person is a very prominent person, they will not accept. But someone will prefer maybe to go to Aga Khan or maybe Nairobi Hospital because of a certain level of treatment.
Okay.
Yeah.
And now that infrastructure is one of our biggest issues, engineer, so from learning from COVID-19, even ventilators, there's so many things. What do we lack as a country that we cannot produce these things on our own? Because we have engineers like you. So what's stopping us from making ventilators and many other equipment that could be useful even for medical purposes?
Thank you so much, Nelima. I would say that I would blame the government at this point. Why? Because we've had very bright minds coming out from our institutions of learning who have actually come up with different medical equipment prototype, and they presented them to the government, for approvals and even for support. You remember right now, majority of the people who are actually working on these particular prototypes are young engineers. The very old engineers, probably the kind of equipment that they had were very old technology, but the current coming generation are the ones working on the prototypes for different equipment, ventilators, we have the suction machines, we have different kind of equipments that we are using across across the country. And biomedical engineers have put a lot of effort. We even came up with some that we are taken to KEBS for approval, and they approve, but there's no support from the government. You see, if they can just embrace the local biomedical engineers and empower them, to enable them to produce this locally, then I think we'll be very far. I know President has really worked so hard in terms of promoting the Juakali industry guys. So he can just go a step ahead, and plus our CS, CS of health, they can just go a step ahead and identify these biomedical engineers who have the capability of production of this medical equipment. We just need a design and a prototype. Then the rest of the things, the government buys the items and we design these equipments, because it's not rocket science. We learn them in school.
It is possible.
It is very possible. Only that we lack support, we lack resources, and you see, we don't have the right, goodwill of the government just to. They seem to have really believed on the other people coming from outside than us who are being produced from within the country. So this is very possible, Nelima, and I challenge the government to pick it up. I mean, with the current biomedical engineering team. And we'll be very, very far.
Yeah, because you see, Kenyans are decrying the high costs.
Yeah.
And very few Kenyans are catered for by insurance companies and even NHIF, which is just about 30% of Kenyans. So we are in need of these services. And we need them to be lowered so they can be affordable across the board.
That is very true, Nelima. Initially, when I was just learning my biomedical engineering when I was in school, most of the engineers that were biomedical engineers who are maintaining the equipment in different hospitals were biomedical engineers from India, some from Germany, some from different countries. And, but right now, if you go across the country in different hospitals, come to Aga Khan, go to MP-SHA, go to Nairobi Hospital, you will not get, an engineer from outside the country. We are all maintaining these equipments here. And these big hospitals that you're talking about have more than 2,500 equipments. I mean, starting from the lowest, like a stethoscope, all the way to an MRI. These equipments are being maintained by the in-house biomedical engineers. So if we are able to maintain the MRI equipment and we are able to maintain the CT scanners, we are able to maintain this equipment that are treating cancers, why can't we develop a small prototype or a ventilator? It is very possible. We just need the support of the government. We'll be available for the resources, and we get the support of approval from KEBS. And then we are good to go. And of course, embraced by the Association of Medical Engineering of Kenya, then we are very much good to go. Then this cost of healthcare, we are going to bring it down a bit, especially when we are pegging our cost on the equipment that we purchased in different areas. Then we can be sure that this locally manufactured equipment are going to be very, very cheap as opposed to the ones that are imported.
Okay. And a few months ago, there was a report of medical equipment that have been imported but have not been used across different counties for a very long time. So what are your thoughts on the same? Even as we're using a lot of money to import medical equipment. So is it that we don't have the expertise, that the equipment are lying in stores with nothing, no use? What could be the issue?
Nilima, I think you're talking about the Medical Equipment Managed Service, the MES, Managed Equipment Service, MES. Yeah. So the MES was a very good project that the government had in mind. However, it did not take place the way it was intended to. And I wouldn't say that we don't have expertise. Expertise are there, but the resources are not there. Let's say, for example, I want to install a CT scanner, because most of these equipments, there were CT scanners, the MRIs, and the X-ray machines, and the ultrasounds. These equipments have specification of the kind of a room where you need to install them on. You cannot just come here and install an MRI here. So the government had actually decided on which counties they were going to give this particular equipment, and they were given, but they had not looked at the nitty-gritties on the ground. Is this county having power? There are particular counties which do not even have backup generators for their equipment. And you see, for an MRI, if there's no power for like 30 minutes, then there's something called helium that will quench and the gas will go. And for you to fill an MRI machine with that helium, you need 1 million shillings to fill. So you see, if we did not put these infrastructural details in place, then the equipment will lie there.
It is pointless.
Yes, so it is pointless to have this equipment, Nelima. So what happened is that the government had a very good intention of having this, but the equipment were imported, supplied to different counties. Some are working, but some have never been installed because of lack of utilities. There's no power, right power required. I need 3-phase, I only have single phase. I can't use this CT scanner machine. You know, I need a biomedical engineer to come and install this machine. This particular facility doesn't even have biomedical engineers, or if they do have, they only have the few ones who are able to run with the kind of equipment that are there. I cannot chuck that biomedical engineer from the normal operations to come and sit here for 3 weeks or 2 weeks doing installation. Then it means the rest of the wards are going to suffer. Yeah. So maybe what government needs to do is to invest on their biomedical engineering, professions. Let them employ. We have very great minds, Nelima, in biomedical engineering fraternity. These equipments can be installed. They can be given. They didn't consult wide. You know, Yeah, so they need to have these people and just have them in mind and put them across in the hospital. We will see all these equipments working. Right now, we are paying for them. We are paying the vendors, and we are not using them anymore. Why? Very dearly.
Yes.
And you know what? We are putting this cost on the common Wananchi. I go to the hospital to be done for an MRI. I pay dearly. Why? Because I want to pay back this money. Every month, this amount of money that the county is paying, you know, to ensure that we pay back the vendor. Otherwise, the vendor will sue us because we had an agreement anyway. Whether you're using it or not, I need my money back.
Okay.
Yeah.
And the universal health care.
Yes.
You know, it was rolled out 2 years ago, and it was the aim of the government by 2022, which is a few months away, that every Kenyan is going to be catered for, the health care. So if that is rolled out, of course, it can be achieved by next year. But if that is rolled out by the government, does that mean insurance companies are going to be in trouble? Health insurance?
No, I don't think so. Because the universal health care, it is there to support mwananchi wa kawaida.
Yeah.
And according to the current things, the way they are going, not each and every person will be catered for it. Or it will not cater for each and every person. So I think it is coming to just add up on what maybe the insurance have been doing, and even to support on what the insurance have been supporting.
Okay.
Yes.
And even as we conclude, I'd just like to pick your minds on what your big idea is on solving the burden that is the cost of health on very many Kenyans. I'll start with you, Mwangi.
Okay, thank you. To me, what I would think, what I would say is that at first, what engineer was talking about, the government of Kenya should come and give at least an opportunity to the Kenyan engineers, because if these people are given at least an opportunity to explore what they have with them, and even at least be given what it is worthy for them, because most of these people, they've gone outside working for the other government and coming back, because whatever they've worked for, or maybe what they've prepared, even those machines and all that, it is coming back to our country being more expensive, and it is something which would be done in this country. But the Kenya government have not given opportunity to those people or to those engineers and even to doctors. You find even a doctor, a very professional doctor, has gone outside the country to be employed instead of working here in this country. The same thing when it comes to the insurance. If the government would partner with some of the insurance, I think the cost of the living would be more cheaper, because the government would say, I'm going to cater for this, the insurance caters for this. That would work very.
So it becomes less heavy on Kenyans.
Yes.
Okay. Yes, and Ms. Alo, what is your big idea of, lessening this burden, huge burden of cost of healthcare on Kenyans?
Okay, thank you so much. As the Secretary General for the Association of Medical Engineering of Kenya, AMEC, I would advise the government to be more on employing their own citizens. That is number one. Like the other day, they were talking about Cuban doctors. They are very expensive, yet we have our own doctors here. It saddens me to hear, Nelima, you are saying that you have equipment not installed because you don't have expertise, yet we have so many biomedical engineers who are jobless and looking for jobs. So I would really, really emphasize on the government giving employment to the biomedical engineers and even their own clinicians. We don't import people, and yet we have enough resources, human resource within us. Number two, I would also talk about the evading of tax. Removing tax from different medical equipment. Okay. That would really ease the burden for the common mwananchi. Yeah.
Okay. Thank you so much, ladies and gentlemen, for being part of the conversation. Engineer Millicent Alo, Association of Medical of Engineering of Kenya, AMEC, and Mwangi Peterson, Manager, Jubilee Insurance. We've come to the end of the conversation here on The Big Idea. We have been talking about the state of healthcare in the country. Many Kenyans have to dig deep into their pockets to pay for medical services, and it is a burden to very many of us here. And we're just trying to address that problem and probably come up with possible solutions of easing the burden of the high costs of medical care. I am Nancy Nalima. Thank you so much for watching.
We value your feedback and welcome